Hello, my name is George Mexicano, and I'm a professor of medicine in the section of infectious diseases at Oregon Health and Science University. Today we're going to be talking about different causes of fever, and it's a case-based presentation, which I've entitled 10 Cases of Fever, 10 Lessons Learned. So, the first case is a 32-year-old woman who presented in July with fever, severe headache, muscle aches, conjunctivitis, and nausea. When she was asked about contacts with similar symptoms, she denied that anybody around her had been sick. 10 days before the symptoms began, she had actually been doing some kayak drills in a roadside pond. And a kayak drill is where basically you purposefully capsize in order to be able to right yourself. And the idea is to practice that before you get into big bodies of water. Well, it turns out that her illness was due to Leptospira interrogans, which is the causative agent of leptospirosis. This organism is a spirochete. There are over 200 serovars or types of this species, and it is an organism that has animal reservoirs. The issue there is that in the animals that are infected, you have a persistent infection in the renal tubules, and so these animals can excrete the organisms in their urine for a prolonged period of time, months if not years. And so any body of water potentially can be contaminated. Worldwide, the animal that's most implicated are rats, but in the United States, dogs and livestock, such as cattle, horses, and pigs, cause more disease. So if you're thinking about leptospirosis worldwide, think of rats. If you're thinking about leptospirosis in the U.S., think of dogs and livestock. And what happened here basically was that one of these animals, or perhaps many animals, were urinating, and that urine made its way into the roadside pond, and then because of the kayak drills, her mucous membranes were exposed and she developed leptospirosis. And here are the risk factors for getting this infection. There are occupational groups, that's on the left-hand side of the slide. So farmers and ranchers, abattoir or slaughterhouse workers, trappers, veterinarians, loggers, sewer workers, military personnel, and people who work in rice fields. But in the U.S., actually the bigger exposure, or risk factors, I should say, involve recreational activities, including freshwater swimming, canoeing and kayaking, trail biking, and hunting. And of course, because the domestic animals can actually be infected as well, the household environment is potentially a risk factor as well, especially pet dogs, but again, domestic livestock. And there are some places where there are rainwater catchments where rainwater is essentially captured, and rodents can get into those rainwater catchments and contaminate the water. So lots of risk factors for this organism. The clinical disease in humans has a broad or a wide spectrum of manifestations. Some infections are subclinical, but some are so severe that they lead to death. The incubation period is usually in the order of weeks, but it can range from 2 to 20 days. And there are two quite different and recognizable syndromes, each with two classic phases that involve basically high fever. So you have a biphasic febrile illness. What that means is a few days of high fever, and then the fever resolves, and then a few weeks later, fever returns. If there is icterus, then it's called Weil syndrome. If it's more like an influenza-like illness, then that is typical leptospirosis. That accounts for approximately 90% of cases. It's actually easily treated if you think about it in terms of the diagnosis. Doxycycline and amoxicillin can both cure this infection, and you can prevent the infection as well. Domestic livestock and pet dogs can be vaccinated, and however, even when vaccinated, they potentially can still excrete the live organisms in the urine. So they won't get sick from the organism, but they might still be a reservoir. In military operations, it's been shown that oral doxycycline, 200 milligrams weekly, can prevent this infection. And then, of course, there are other things like wearing protective clothing, rodent control measures, and avoid swimming in freshwater bodies of water, particularly places where there have been likelihood of many animals, including domestic livestock, surrounding those bodies of water. So the first case was a case of leptospirosis, and the theme there is that people do strange things, and so a good history is important. And that's going to be a similar issue with the second case. History is important. So the second case is a 44-year-old man who presents with both fever and shortness of breath. He has a dry cough for 2 months. He has lost 15 pounds, and he feels very weak. He's an avid sportsman, and he likes to camp in northern Wisconsin and the Upper Peninsula of Michigan. His dog died a few weeks before he presented. And here's what the chest x-ray showed when the patient came to seek medical attention. So there's an interstitial butterfly pattern that was fairly unimpressive from the radiologic perspective. But nonetheless, because of his symptoms, the pneumonia was indeed diagnosed. Well, it turns out that this was a case of blastomycosis. The presentation can mimic TB and cancer because of the weight loss and the prolonged symptoms. And the good news is that the organism is very readily isolated. It's very easy to see. And just a regular sputum sample will reveal the diagnosis if you get a fungal stain 86% of the time. And if you do a bronchial washing, virtually every time you'll find organisms. There's also a urinary antigen assay, but the issue there is that its role in diagnosis is a little bit not controversial, but it's difficult to know for sure what its role is. So you can't sometimes distinguish active disease versus older disease. But the other issue, of course, is that there's some cross-reactivity with other fungal organisms, such as Histoplasma capsulatum. If you were to get a sputum or a bronchial wash and did a fungal stain, this is what you would see: broad-based budding yeast, the classic picture for Blastomyces dermatitidis. And this is just a map of the United States outlining the geographic areas that are endemic for the 3 dimorphic fungi. They're called dimorphic because they have a filamentous form at one temperature and a yeast form at a different temperature, so dimorphic. So along the southwestern part of the country, you see the little C that stands for Coccidioides immitis. So Coccidioidomycosis is in the desert southwestern part of the country. The blue triangular-shaped geographic region has the little H by it, and this is the geographic area that's most associated with histoplasmosis. I usually think of it as the Mississippi, Missouri, and Ohio river valleys. And then finally, the last geographic pattern is the areas that are associated with blastomycosis. And this person had gone camping in northern Wisconsin, and that's where he obtained the organism. The organisms live in the soil for all 3 of these dimorphic fungi, and you can breed the spores in and get infected via a respiratory exposure. Okay, the third case is a 53-year-old man who presented to the emergency department with a 5-day history of sharp left lower quadrant pain and constipation. 1 day prior to presentation, he developed fevers and chills. Because of his presentation, the emergency medicine doctors that initially saw him obtained a CT scan of the abdomen and pelvis, and that revealed a large bowel obstruction and diverticulitis. So he was admitted for bowel rest and started on intravenous antibiotics, initially ciprofloxacin and metronidazole. Well, overnight, the pain actually worsened and worsened dramatically, and he actually developed peritoneal signs. So a repeat CT scan was done, and this now showed free air in the abdomen with the signs of a bowel perforation. So he was taken to the operating room for emergent exploratory laparotomy, and the surgeons found that he had both cecal and sigmoid diverticuli that had perforated. So he underwent a right hemicolectomy, a sigmoidectomy, an endoileostomy with a Hartmann's pouch for these perforations. And here is a CT that showed the free air in the abdomen. And this is a picture from the operating room that showed the fecal contamination from the perforations. Well, the antibiotic treatment was continued because of the contamination into the abdomen, and the antibiotics that had been initially chosen, ciprofloxacin and metronidazole, were continued. But despite the source control, meaning the surgical procedure, the patient remained febrile for days, and his white count did not improve. It continued to hover around 16,000 for 4 days in a row post-operatively. Interestingly, there were no localizing symptoms, and the surgical wound was clean and dry. The drains looked good, and the abdominal exam was actually benign. But because the fever was continuing and the white count wasn't improving, he again had imaging, and lo and behold, they found a 7.5 by 6 centimeter intra-abdominal abscess that required a new percutaneous drain placed by interventional radiology. So this is basically a case of treatment failure. So if you have a patient with persistent or recurrent clinical evidence of intra-abdominal infection after 4 to 7 days of therapy, the recommendation is to re-image the abdomen and pelvis because most likely they have developed an intra-abdominal abscess. For patients who do not respond and the focus of the infection remains, you need to repeat cultures to obtain, basically purulent material from the abscess, and you want to make sure that you do susceptibility testing on the anaerobes to make sure that you're not dealing with a resistant anaerobic organism. And the important microbiologic issue here is something called aerotolerance. Bacteroides fragilis, which is a common organism in the bowels, can spill into the abdomen, and what happens is that they can survive that initial shock of being exposed to oxygen and basically hang on until the oxygen tension once again drops. And so several days post-operatively, they start to grow and can form these abscesses. So let's go on to the fourth case. The fourth case is a 41-year-old immigrant from Peru, and this patient presented with new onset tonic-clonic seizures. She had never had any seizures before. She denied any other medical problems, and she was on no medications prior to her presentation. She had no headache, motor weakness, weight loss, GI symptoms, and denied HIV risk factors. But she had felt feverish, but without sweats or chills. Because of the new onset seizure, the emergency medicine physicians obtained a head CT, and that revealed a cystic lesion that had something inside of it, as shown at the top of the slide. And what she ended up having was neurocysticercosis. And what you're seeing here are the eggs of the pork tapeworm. The pork tapeworm is called Tinea solium, and these are the eggs. So let's talk about cysticercosis. So cysticercosis is the infection of the larval form of this organism, of this parasite. And again, the parasite itself, the pork tapeworm, is called Tinea solium. The adult worms are found in the human GI tract, and they pass thousands of eggs every single day. If those eggs somehow contaminate areas where they are then ingested, then what happens is that the eggs can eventually form larvae. So pigs or humans eat food that's contaminated with human waste, and if they ingest the eggs, the larvae from those eggs make their way via the bloodstream to distant sites, and they will form cysts. If it's in the brain, it's called neurocysticercosis. If it's anywhere else, it's simply called cysticercosis. So in contrast to the larval form of the disease, which is what we're describing right now, having the adults themselves is called teniasis, and that is obtained when humans eat undercooked pork and ingest encysted larvae, which then mature into the adults, and the cycle can repeat itself. And that's shown here from this life cycle from the Centers for Disease Control and Prevention. I'm going to start at the 9 o'clock position where it says number 5, the scolex, which is basically the head of the parasite, attaches itself to the intestine. These adults are very, very long, and they can release thousands of eggs or what are called proglottids, these segments of the tapeworm, into the stool. And these embryonated eggs and or the proglottids, which contain the eggs, can be ingested by pigs or humans. And then once they hatch, then the organism can penetrate the intestinal wall and circulate to the musculature in pigs and as well as in humans, and they will then form cysts. And so in pigs, that's where they will basically have viable cysts for a long time. And then if this pig is slaughtered and the pig is eaten and the pork is eaten and it's undercooked, then those cysts can form adults and the cycle repeats itself. However, what happens in humans is that when you eat the eggs, the larval form can actually migrate to other parts of the body, including the organs, and if it gets to the brain, then you can get neurocysticercosis, and it's the #1 cause of seizures in Latin America, and that's everything from Mexico down to the tip of Chile. And so let's move on to the 5th case, and then we'll summarize the 5 lessons for the first 5 cases after this case is finished. So the 5th case is a 54-year-old homeless man who develops severe fatigue over a 3-month period. He then develops shortness of breath and painful spots on his hands and feet. He seeks medical attention in urgent care, and the exam reveals a loud murmur, and an echo reveals vegetations on the mitral valve when he's admitted. Off antibiotics, all the blood cultures are negative. So this appears to be a case of culture-negative endocarditis. And here you can see Osler spots and Janeway lesions, as well as Ross spots, the classic findings of infectious endocarditis. Well, the microbiology of infectious endocarditis, or IE, has changed somewhat. Staph aureus is now the most common cause worldwide. It's approximately 31% of people with endocarditis. That's the causative agent. And other gram-positive organisms are certainly important. Viridae and Streptococcus, which are streptococcal species that live in our mouths, and especially along the gingival crevice between their teeth and gums. Coagulase negative staph on the skin, and Enterococcus in the stool and potentially in the genitourinary tract. So lots of organisms can cause endocarditis, and typically cultures are positive. However, 10% of the time, what happens is the cultures are negative. And classically, we used to talk about the HEC organisms being the predominant cause or thing you need to think about with culture-negative endocarditis. And you can see near the bottom of the slide that HEC, H-A-C-E-K, causes 2% of endocarditis, and that the H stands for Haemophilus, the A for Aggregatibacter, the C is Cardiobacterium, the E is Eikenella, and the K is Kingella species. Fungi and yeast can also cause culture-negative endocarditis, and especially Candida species are associated with people who have lines or who are immunocompromised, and they can lead to bloodstream infections. But it turns out that there have been new organisms that have emerged as more common causes of culture-negative endocarditis. Coxiella burnetii, which is the cause of Q fever. Bartonella species. There are staph and strep species that are more difficult to grow. There are unusual organisms such as Trophorama whipplei, which causes Whipple's disease, and then at the bottom of the slide, Legionella, Chlamydia, and Brucella are all associated with this as well. In this particular case, this patient had endocarditis due to Bartonella. So there are two species, Bartonella henslei and Bartonella quintana. Both species occur across the globe. Bartonella henslei is transmitted via exposure to cat scratches and cat bites, and it's the etiology of cat scratch disease. Bartonella quintana is the cause of trench fever, and which is seen in refugees and in military operations. And the vector for B. quintana is the human body louse. So human lice are associated with Bartonellosis. Well, endocarditis from Bartonella is associated with alcohol dependence and homelessness. And interestingly, a significant portion of people affected are afebrile, but they and as such, they can present with advanced valvular disease as well as embolic phenomenon. And you can diagnose it with culture, but most people will either use serology or PCR testing to confirm the diagnosis. And so I've described so far 5 cases, and hopefully you are thinking about lessons learned from a diagnostic and therapeutic perspective with regards to these cases that presented with fever. So the first case was a case of leptospirosis, and the lesson there is that people do strange things, like kayak drills. The second case was a case of pulmonary blastomycosis, and the point there is history really does matter. Where do they live? What have they done? Where have they traveled? The third case was an intra-abdominal abscess that formed following an exploratory laparotomy with bowel surgery. And the point here is if the patients are not getting better, keep looking for an answer because things have changed. The fourth case was a patient that had neurocysticercosis. And the idea there is even though they presented with a seizure, think about infections even when they are not likely. And then finally, the last case, the fifth case, was the case of Bartonella endocarditis, and the lesson there was that unusual organisms may cause relatively common diseases. So those are the first 5 lessons. Let's now go on to the next 5 cases, starting with case number 6. So case 6 is a 27-year-old public health nurse who was referred to the outpatient infectious disease clinic because of a 4-week history of malaise, fatigue, and daily fever. Except for a broken right ankle, the past medical history was completely unremarkable. She denied having any other symptoms. Her primary care clinician had done a pretty good workup that included a normal complete blood count, a normal rheumatoid factor, or normal ANA, anti-nuclear antibody. The electrolytes, creatinine, and urinalysis were also normal. Her ALT was 85, the AST was 91. The sedimentation rate was 48, and the CRP was 3. An HIV ELISA test was negative, a monospot test was negative, and the serologic assays for hepatitis A, hepatitis B, and hepatitis C were all negative. When all the blood tests and urine tests came back negative, then there was concern about lymphoma, and so a CT scan of the was done of the chest, abdomen, and pelvis, and all it showed was a simple cyst in the liver, nothing major. An echo was done, and that showed no vegetations. Urine and blood cultures were negative, and 3 blood cultures were obtained. All of them were negative. And so the primary care clinician referred her to me in the infectious disease clinic. And when I saw her, the patient appeared tired and had normal vital signs in a normal examination. So arguably, she now has met criteria for a fever of unknown origin. There were documented temperatures over 101 degrees Fahrenheit on several occasions. The duration of the fever had been longer than 3 weeks. and an extensive workup had been unrevealing. In the past, that workup had to be in the inpatient setting. In the modern era, that workup can be in the outpatient setting, and that's what happened with this patient. It was all in the ambulatory setting. Well, FUOs, or fevers of unknown origin, have multiple, or can be caused by a variety of processes. Somewhere about a third of the time, it is due to an infectious disease. Just a little bit less than that, it's due to some sort of malignancy. Between 10 and 20% of the time, it's due to a collagen vascular disease. And then there is a smattering of other things, miscellaneous conditions such as drug fever and things like that. But sometimes, approximately 10% of the time, it's actually unknown, which basically means that there are probably other organisms or other causes that we have yet to discover that are associated with FUOs. Well, it turns out that this patient actually had mononucleosis due to Epstein-Barr virus. And I did mention that she had a negative monospot. But the follow-up test, the test that I did, was actually to get a full serologic assay for the antibodies associated with Epstein-Barr virus. And so there are three of those, the VCA-IgG, which stands for viral capsular antigen, IgG, viral capsular antigen, IgM, and something called the EBNA, the Epstein-Barr nuclear antigen. And the point is that the heterophile antibody, which is the monospot, can be negative even when the patient actually has an acute infection from Epstein-Barr virus. So I'm looking at the top row. You can most of the time, or many times, the monospot will be positive, but if it's negative, it does not actually exclude mono. So if the case looks like mono, it probably is mono. And so do the full serologic panel, and if you get a VCA, IgM, and IgG, it's positive. With a negative EBNA, then that's your answer, and that's what happened with this patient. Okay, moving on, case 7. 43-year-old woman. She had been traveling to Central America. She went to Costa Rica because she was a birder. She wanted to see as many birds as she could on her list, and so she traveled to the rainforests. She took our advice and had been seen in the travel clinic and had obtained and took malaria prophylaxis, but she despised insect repellent because she didn't like chemicals on her body, didn't like topical or sprays or lotions of that type. So malaria prophylaxis, yes. Insect repellent, no. When we saw her, she reported pain behind her eyes, a severe headache, muscle aches diffusely, fevers and chills since returning, and she had been there for about 10 days and had returned 3 days ago at the time that I initially saw her. Well, this patient, it turns out, had dengue fever. And you can see here the worldwide distribution of dengue, certainly in Central and South America, as well as Southeast Asia, including the Indian subcontinent, and in Southern Africa, but not generally Sub-Saharan Africa, and that's important for the reasons which we'll go into in just a minute. This slide simply shows that dengue is becoming more common as people encroach more and more into wild areas like rainforests. They are being exposed more and more to the insect vector, which is Aedes aegypti. It's the same mosquito that transmits yellow fever. And Aedes aegypti is a daytime feeder, so you have to wear insect repellent during the day as well as during the night. The Anopheles mosquitoes, which are the vectors for malaria species, are nighttime feeders. So the point here is that you need insect repellent both during the day as well as preventive measures such as bed nets during the evening. Well, if you look at the common causes of fever by geographic area, especially in a returning traveler, the point of this slide is that actually dengue is the thing you should think about first, and malaria second. The exception is at the bottom of the slide. If they've traveled to sub-Saharan Africa, think malaria first, second, and third. But for other parts of the world, you should think of dengue first, especially in a case like this where the patient took and adhered to malaria prophylaxis. We always worry about malaria resistance, and so you have to certainly look for malaria. But in this case, this was dengue. And on the right-hand side of the slide are other common infections in returning travelers. So the eighth case involves a 34-year-old truck driver who sought medical attention because of an intermittent fever. He had lost his appetite and had unwillingly lost 10 pounds. He also had tremendous fatigue, but denied other symptoms such as cough, shortness of breath, muscle aches, GI symptoms, or rash. And the fevers tended to wax and wane every 1 to 2 weeks, but they had a sort of a specific pattern when they were present. It turns out that when we asked the patient to do a fever curve, it looks something like this, that every couple of days he would spike a fever, and the fevers were high, 103, 104, 105 degrees. And then over a week or two, then they would resolve, and then a few weeks later they would come back again with this every other day pattern. And this is a Powell-Epstein fever, which is the classic for lymphoma. And that's what this patient ended up having. So the fever pattern matters. It matters not just in lymphoma, but it also matters in malaria. As you can see here that 3 of the malarial species, Plasmodium vivax, Plasmodium ovale, and Plasmodium falciparum, they will have fevers basically every other day, whereas Plasmodium malariae has basically 2 days where they're afebrile, and the first and fourth day are febrile. So the 9th case involves a 34-year-old man who presented with a 1-week history of cough, fever, and mild confusion. His exam was normal, except for a temperature of 104 degrees. His pulse was 108, so he was tachycardic. He also was tachypnic with a respiratory rate of 24, and there were RALs in both bases. The room air PO2 was 66, and that was obtained by blood gas. The O2 saturation was actually in the mid-80s. His hematocrit was 32, and the white count was 6.4 without a neutrophilic predominance. His transaminases were normal. And a chest CT was obtained and showed this interstitial pattern on both sides. So an interstitial pneumonia is what he was diagnosed with. An HIV ELISA test was positive, and the Western blot was also positive. So he was found to have the HIV, to have the human immunodeficiency virus, and his CD4 count was only 6, and so that then confirmed that the diagnosis was in fact the acquired immunodeficiency syndrome, or AIDS. So this patient had AIDS and had presented with an interstitial pneumonia. So sputum was sent for Pneumocystis jiroveci. That's the new name for Pneumocystis carinii. The stain is called a TBO stain, and it showed these saucer and cup patterns of this organism, Pneumocystis. So the patient was started on trimethoprim sulfa and prednisone, but did not improve. So the TMP sulfa is important for the Pneumocystis. The prednisone is important because his oxygen saturation was low, and so it's been trials have shown that you have to add steroids to Pneumocystis pneumonia when there's hypoxia. So he was treated appropriately for Pneumocystis, and he had Pneumocystis, but he did not improve. So the clinicians taking care of him continued looking for things, and his respiratory status worsened, and so he had to be intubated. And sure enough, when a lavage was done at BAL, it showed that the patient also had cytomegalovirus. So he had a co-infection. He had HIV/AIDS, he had Pneumocystis, but he also had cytomegalovirus, or CMV pneumonitis. He slowly improved after ganciclovir was added to the regimen, and unfortunately, he could not tolerate the antiretroviral therapy, but he did well with regards to his lungs with long-term secondary prophylaxis for both Pneumocystis as well as CMV. So the point of this is that immunocompromised patients can have more than one problem simultaneously. And the case I just talked about was a case of with a patient that had HIV/AIDS, but we also see this in transplant recipients. So if a transplant recipient does not receive prophylaxis with TMB-sulfa, then you can have a large number of them, greater than 25%, can come down with this infection. There is often a prodrome that's pretty short, and they can be hypoxic and use steroids if that's the case. And you see that it can be treated and the patients can do well if caught promptly. So basically, you have to give prophylaxis for transplant recipients, including bone marrow transplant recipients, longer if there's GVHD, which is graft versus host disease. You also have to treat or prophylax people very long, more than a year for if they're a lung transplant recipient. Now, the other point of this case is that a specific diagnosis is actually very important because patients can have more than one problem. And so optimal treatment for each agent is unique. In addition, you can have both infectious causes, in this case CMV and Pneumocystis, but you can also have non-infectious causes that can present in an identical manner. And finally, there are other reasons to have specific diagnosis in these kinds of patients is that early treatment of some infections actually is associated with improved outcomes, such as Aspergillus species. So the final case, case 10, involves a patient who presented with fever and abdominal pain, nausea, and vomiting. She had a long history of alcohol dependence, and because of where the pain was at in her history, the clinicians that took care of her obtained an amylase and a lipase, and they were both highly elevated, and basically she had pancreatitis. So the point of the last case is that there are non-infectious causes of high fever. They include malignancy, especially lymphoma and renal cell carcinoma. That fever is one of their sort of hallmark presenting signs. Collagen vascular disease, such as lupus, rheumatoid arthritis, temporal arteritis, and many others can present with fever. There are certain granulomatous diseases that are non-infectious, such as sarcoid, granulomatous hepatitis, and others. Drugs can cause fever, including antibiotics such as sulfa and penicillin and ciprofloxacin, but also other medications such as the seizure medications like phenytoin, they can certainly present with fever as well. And then just to make sure that you sort of at least have this in the back of your mind, sometimes fevers can be factitious. I've seen, unfortunately, a number of cases where people were actually essentially either malingering or had Munchausen's, and they were basically trying to fake being sick from an infectious disease perspective. So we had 5 lessons earlier, and so here are the second set of 5 lessons for 5 more lessons learned. The 6th case was a patient with mononucleosis due to Epstein-Barr virus, and she continued to have fevers for weeks, and so she was worked up extensively as part of a fever of unknown origin. And the lesson there is that common things are common. If it looks like mono, it probably is mono. Don't just stop at the monospot test. If you really think that's what this is, go ahead and obtain the serologic assay for Epstein-Barr virus. The second case was a case of dengue fever in a traveler to Central America. And the lesson there is if you have a fever, if you see a patient, returning traveler who has fevers, think first of dengue, and second malaria. In thinking about this, the exception is sub-Saharan Africa, where dengue rarely occurs, but everywhere else, think dengue. The eighth case was a patient with Hodgkin's lymphoma who had a waxing and waning fever and with high fever spikes every 48 hours. So pay attention to the pattern is the lesson learned. The ninth case was a patient who was immunocompromised because of HIV/AIDS and ended up having two other infections, CMV pneumonitis as well as Pneumocystis jiroveci pneumonia. And the point here is that when someone has a decreased immune function, that you should throw out Occam's razor, right? Occam's razor is that usually there's, one unifying diagnosis explains everything. Well, that's true, except when people are immunocompromised. And then finally, the 10th case was a case of pancreatitis, and the lesson there is that not all fevers signify infection. So hopefully you found this both interesting and compelling, and that you have learned some ways to think about patients who present with fever. And the idea here is think broadly, make sure that you be persistent, and if the fevers continue, if the patient is sick, keep turning the stones over and you will be able to find the diagnosis in most cases. So thank you very much. It's been a pleasure, and have a great day.